Thank you very much, first of all, for your kind invitation to be part of this conference. I'm very pleased to be here and very honored to be here with you because, of course, all the scientific and clinical community is with you and wants to provide you all our support. My name is Giovanni Baranello. I am based in London. I'm associate professor of pediatric neurology at UCL and Great Ormond Street Hospital. I was trained in Italy, actually, as you can easily imagine from my name. And then I moved to the UK in 2019. And here I'm involved in management of and diagnosis of children with different neuromuscular conditions, in particularly children with the Duchenne muscular dystrophy, spinal muscular atrophy, and other conditions. And I'm also involved in clinical trials to find a treatment for these neuromuscular disorders, including Duchenne muscular dystrophy. So what I will try to do today is to share some of the guidelines to manage Duchenne muscular dystrophy, but also try to give you some more of our experience, you know, in how we manage these patients, and also to give you some very recent update on how we are slightly changing, you know, our approach, our multidisciplinary care of these patients. I will share the screen now. Is it okay that I start?
Yes, please do.
So I hope that I will not repeat something that has already been said today by my previous illustrious colleagues, but just to say that essentially we have now demonstration, you know, compared to the past, that if we have a very proactive management and also an anticipatory management, try to anticipate the onset of side effects or comorbidities in this condition, we can significantly change what is the progression. So for example, you can see here the dramatic change that we have seen after the introduction of spinal surgery or the non-ventilatory, non-invasive ventilation in prolonging survival in patients with Duchenne. And then the implementation of the steroids also helped in prolonging ambulation and also delaying death. And of course, this is very important because we know that already by doing this without any treatment, we can significantly affect what is the trajectory of this disease. And I'm sure that you are very familiar with this picture showing that essentially a number of processes and professionals are implicated since diagnosis, since the first meeting with these families and with these patients, in order to provide to them the best available care. You know that there are different stages of the disease, from the early ambulatory to the late non-ambulatory, and for each of these stages, we now know from the standard of care that we can put in place several approaches, either on neuromuscular management or on rehabilitation, endocrine, cardiac, respiratory management that can improve the quality of life of these patients. The first aspect that I would like to remark is that early diagnosis is important in this condition. Unfortunately, I'm not sure, I'm sure that in Ukraine, you know, doctors are very good in early detection and early diagnosis of patients with Duchenne muscular dystrophy, but this is a very important aspect because, of course, the early we start the management and you know, the treatment whenever possible, the better would be the outcome on the long term, because we still see patients that are referred to us still when they are a little bit older, you know, than expected, like 6 or 7 years, because they have been misdiagnosed, or they have undergone other investigations, like, for example, liver biopsy when there was increased transaminase, without suspecting that that could be related to a neuromuscular problem like Duchenne muscular dystrophy. So early genetic diagnosis is very important. It's very important also the counseling that we give to the families. We used to provide the testing for the carriers and prenatal and testing as well to the families. We will see that we have some approved treatment here that we try to start as soon as possible. We try to provide support to family immediately after diagnosis, connecting them to the advocacy groups. We have several advocacy groups and charities here in the UK that provide a lot of support, a lot of material, a lot of leaflets, you know, and counseling especially to the newly diagnosed families. Because it's very important to be very well oriented on what to do, because of course this is very traumatic, you know, for every newly diagnosed families. In terms of neuromuscular assessment, we used to see patients every 6 months, and you see here a number of assessments. So of course, physiotherapy assessment is one of the main aspects that we try to focus on, because we want to optimize muscle strength and function. We want to promote participation and access to education for these children, you know, when they grow up. We provide wheelchair service whenever possible, you know, manual wheelchair or a power wheelchair when they lose ambulation, of course. We provide orthotics review and recommendation. And of course, we organize all this multidisciplinary management, including dietitian, cardiologist, pulmonologist, the endocrine professionals, orthopedic, and so on, because we know that this is very important. The North Star assessment is one of the main functional assessment that we use in clinic, of course. And this is now used not only in the clinical setting, but also in the clinical trial to monitor the progression of the disease and also to capture very early signs of a possible efficacy, you know, when there are treatment that are under investigations in clinical trial. And we are now trying to develop some pictures or centiles that are also easily for the families to understand and to monitor their child, you know, every time that they come to clinic, to understand as the children progress, but also what we can do as long as we notice some deterioration with time in some of these items. Corticosteroids management, of course, is crucial and is currently the only treatment that is somehow part of the standard of care. Prednisolone was the first one that was initiated in the North Star network, which is the network here in the UK that links more than 20 clinical centers for neuromuscular patients. But then over the years, also the Deflazacort have started to be used, and I will show you why. And the data that we have. And I will mention to you later on some of the very recent data. Sorry? The translator?
Sorry, it was some moment, but it's okay now.
It's okay. For the steroids, for example, we have seen, while in the past, it was recommended to start steroids when there was a sort of plateauing or a decline in the motor abilities, we now tend to start much earlier, let's say after the age of 4 years, because if we start a little bit earlier than 4 years, there is still not clear agreement about the safety of starting so early. But definitely we don't expect to achieve the plateau or the declining phase. And if we have children who are already diagnosed at the age of around 4 years, we tend to start the treatment, because we have seen, for example, from this paper, that the children who started before the age of 5 in the continuous line here were the ones who had a better outcome on the long term. But of course, corticosteroids have a constellation of side effects, as you see here. They are, of course, associated with the positive effects like improving in energy and motor skills and delaying loss of ambulation and cardiac and respiratory decline. But on the other side, of course, can be associated with weight gain, hypertension, osteoporosis, decreased growth, and so on. And so it's very important that we monitor closely, especially in the first 3 months after starting, but then every 6 months, all the possible side effects. So we monitor weight and height, blood pressure, glucose, bone health, and all, the other possible comorbidities. And as soon as we notice, the occurrence of these side effects, especially in terms of worsening of behavior or worsening of overweight, we tend to adjust the dose accordingly. But you should bear in mind that there is a minimum effective dose, which is considered 0.3 milligrams per kilograms in prednisolone treated patients. You have already heard about bone health in the previous presentation. Just to say that usually we try to provide 1,000 units, and this is sufficient to maintain high levels of vitamin D. We usually want to stay around between 75 and 100 of 25-hydroxy vitamin D in the blood. And we monitor as well with the DEXA and the lateral X-ray if there is a decrease in the bone mineral content, and also signs of vertebral fractures, which is the shrinking essentially of the vertebral bodies. And the previous speaker has already mentioned about this. It's important because now the way in which we approach this is slightly changing. We try to, because we know that this is quite common, we try to flag up this quite soon. And for example, we always inquire from the patients if they have pain in their spine. We touch the spine to feel, especially in the lumbar region, if they feel pain, because this might be a sign of a vertebral fracture. And if there is a vertebral fracture or any other fracture, and if there is reduced bone mineral density below 2 standard Z-score on the DEXA, this is an indication that our endocrinologists consider to start bisphosphonate treatment. Several studies have shown that improves the bone health of our patients. In terms of cardiac management, again, we also have the standard of care guidelines, we have now become much more proactive as well. So we try to monitor patients every 2 years before the age of 10 years, and then at least once a year after 10 years. And now we tend to start after 10 years, both ACE inhibitors and beta blockers immediately after 10, 12 years, even if there are no sign of cardiac impairment on the echocardiogram. And there is recent evidence also that later on in life, another medication like spironolactone or eplerenone can be associated with this medication, because some preliminary studies have shown that this may be effective in protecting the heart. Respiratory function also needs to be monitored. And you see here that the risk is particularly high for non-ambulant patients. But we have shown that corticosteroids, compared to being naive from steroids, somehow protect the respiratory progression, the respiratory function deterioration with time. It's very important also to understand the connection between respiratory management and cardiac management, because we know that patients, even if they have a normal sleep study, they may struggle to maintain a good respiratory function, and sometimes even starting when they are non-ambulant, even starting non-invasive ventilation, especially when there is, for example, signs of weight loss or signs of nocturnal hypoventilation, is helpful to protect the heart as well, because of course patients who are not ventilated may struggle more in maintaining their respiratory function. As soon as patients start steroids, we provide an emergency care plan, because we know that steroids can be associated with adrenal suppression. So it's very important that families are aware that patients are at risk of adrenal suppression if they get an infection or if they need a surgery. So we inform family, we educate family to provide additional hydrocortisone if the child is unwell or if the child needs to undergo a surgical procedure. We provide anesthetic, risk indications, of course, and there is also these issues of heart embolisms that may happen after bone fractures, and these are the signs, you know, to capture early signs of heart embolism for a child, for example, that has experienced falling from a wheelchair or having even a minor trauma, because this could lead to death if not properly detected and managed, of course. Now I want to spend a few words about how we are changing our approach to corticosteroids treatment, because of course in the past there were, and I will show you in a little bit, there were different approaches. You know, we had the intermittent steroids regime, mainly 10 days on and 10 days off. We had the daily regime every day. We had prednisolone 0.75 milligram per kilogram, or deflazacort 0.9 milligram per kilogram. But there was not, and there is not still, a clear consensus on which type of steroids to use and which regime to use. So we had here, to our help, the 4DMD study that essentially was designed as a proper clinical trial for children who were steroids naive between the age of 4 and 8 years. And these are the 3 years data results that have been published this year. So you see that essentially in the green line, you see intermittent prednisolone, and in the red and in the blue line, you see the daily prednisolone and deflazacort. And at the end of the 3 years, you can easily see here that the daily regimes, both of them, showed similar results in maintaining. This is the time to rise from the floor, which was the main motor function assessment, compared to the decline that we have seen over 3 years in the intermittent prednisolone regime. So in terms of efficacy, both the medications in patients who were completely naive from steroids show similar efficacy compared to the intermittent ones. But of course, this was also associated with a different safety profiles in terms of side effects. So you see here that, for example, the daily deflazacort was associated with less gain in weight compared to both intermittent and daily prednisolone, while deflazacort was associated with a worsening of the height, and we know that these children grow shorter if they are on deflazacort compared to the daily prednisolone and the intermittent prednisolone. We have looked very recently at the data in the North Star registry. We have more than nearly 800 patients in our registry with Duchenne, and we had looked at the difference in the trajectory of their growth in terms of height on the left and weight on the right with the different regime. So the yellow is deflazacort intermittent, the orange is daily, the red one is the naive, so patients not on the steroids, and then the prednisolone intermittent is blue, and the green is prednisone daily. And you see here that if we look at the height, essentially the daily deflazacort, of course, not surprisingly, is associated with the higher growth stand, so the patients grew up shorter than the ones of prednisolone. But if we look at the weight, both prednisolone intermittent and prednisolone daily, which is the green line, was as compared along with deflazacort daily, were associated with a higher weight gain, but the prednisolone in particular was associated with a higher weight gain. We see here the age starting of the overall North Star population that we have here in the UK. You know, the median is 5.85. This is 5 years, so nearly 6 years. This is why I said we should try to start even earlier. And this is the change over the last 10, 15 years. You know, at the beginning, we prescribed much more in the past prednisolone, but then over the years, also deflazacort became available, and we started to prescribe also deflazacort. In terms of the regime, you see that intermittent is still quite common, but now daily is becoming much more common. And we also still have some, but much less than in the past, some weekend-only regimes in a very, very few cases. This is in terms of the dose over time. You know that for prednisolone in red, usually should be 0.75 milligrams per kilos, and for deflazacort should be 0.9 per kilos. And you see that, of course, there is, while we try to maintain quite high the dose, you know, close to what is recommended in the early ages, then there is a progressive decline because we tend not to adjust the dose, especially because we know that this is associated with side effects. We try to limit the side effects. And this is a graph that shows over the year how we have tried to lower down the age at which we start steroids, which was much higher, you see here, around 8-9 years, and now is, as I said, around 60 years of age. And this is the time between the diagnosis and the age starting treatment that is also going down slightly. This is the first glucosteroids prescribed in the first year starting steroids. You see that while in the past it was mainly prednisolone, now also deflazacort, and we try to start much more commonly with deflazacort. And here is, which is the regime. So there is 50-50, I would say, when we start the prescription between daily and intermittent. Just to have a look at the switchers, what happens, for example, when patients switch from one regime or one type of steroids to the other. And this is just some picture showing that when we switched from prednisolone to deflazacort, probably there is some improvement in terms of behavioral changes that are, mildly reported or never reported, as you see here. Height restriction, of course, can become bigger problems if we switch from the prednisolone to deflazacort, but weight gain, as we see from this data, can possibly improve a little bit. You see here that after switching to deflazacort, the number of patients where this was mildly reported as a problem was higher compared to before. What happens if we switch from intermittent to daily? We can see some trend in improving the appetite, or in worsening the appetite, or the Cushingoid aspect on weight gain when we switch to daily. So this is something to bear in mind, especially, and to monitor when we discuss this with families. And this is a last slide to show the clinical variability, of course, in patients with different genetic mutation, because we know that, for example, the patients amenable for skipping exon 44 have a better outcome than those on who are skippable for exon 53, for example, or exon 51. So this is also something that we should consider. And there are also some studies on some genetic modifiers that are associated with a better outcome. So in conclusion, it's very important to adapt the approach to this condition, depending on the age and the stage of the disease, and to involve all the key professionals, and also to adjust our management according to the occurrence of the other comorbidities that we see in these patients, because this can really change their natural history and their quality of life. I'll stop sharing here. I'm happy to take any question now for this section.
Дякую, шановний пане професор, за таку чудову доповідь.
Thank you so much, dear professor, for your informative speech. It really is interesting to look at the researches of the efficacy of deflazacort in contrast to prednisolone. We know that it's a very sensitive topic for the patient because the side effect of hormones is quite evident, and the parents very often in Ukraine are scared to take these medications when they read about different side effects. That's why your speech is really very useful for our audience. So I have a question here. Could you tell us, please, is deflazacort widely used in the UK? Because I spoke with one of the colleagues, and that colleague chooses prednisolone. Do you also have some problems or, specifics of the introduction of new medications?
So deflazacort is off-label, of course. It's not like regularly approved for the treatment of Duchenne, but we can prescribe it, and usually we don't have, now in 2022, we don't have any problem in prescribing it. In the past, I know that this was much more difficult, but at the moment, it is not a main problem.
Добре, дякую. Скажіть, будь ласка, а який середній вік встановлений?
Okay, thank you. What is the average age of Duchenne diagnosis in the UK? At what age does it get diagnosed on average, if there is this information?
From the most recent data that we have, it is about 40, around 4 years, 4 years and a half at the moment, as a mean.
Mm-hmm.